Welcome to the 55th Annual Society of Thoracic Surgeons meeting. We are coming to you live from beautiful San Diego, and I'm delighted to be here today with three panelists who presented outstanding presentations yesterday at our seminar on the multidisciplinary team, How We Do It. I'm delighted to be joined by Dr. Michael Grant, who discussed the ERAS cardiac model. He's from Johns Hopkins, as well as John Burnett, an anesthesiologist from Society Hill Anesthesia, and is part of the University of Pennsylvania Hospital System. He discussed initiating on-table extubation for CABG patients. And finally, Min Peter Kim, who's joining us to discuss the ERAS thoracic model, the impact of anesthesia support, and he's from Houston Methodist Hospital. So I'm delighted to welcome all of my panelists here today. I invite them to expand on their introductions as we start with Dr. Burnett. Timing of extubation is certainly a critical element of patient progression. Would you please tell us some of the key components of your program and how that's making a difference for your patients?
Well, first of all, I think it's making a huge difference for our patients. And the reason being is it's not just the patient that we're taking care of, we're taking care of the patient's family as well. And when patients see their loved one in the intensive care unit post-operatively, and they see them on a ventilator with a bunch of tubes in place, with drips next to them, with a Swan-Ganz catheter sticking out of their neck, they are really worried, and their loved one cannot even talk to them or communicate with them. With respect to on-table extubation, what we found is it's really improved our dynamic with our patients and our patient's family, and it's also lifted the spirits of our staff, not only the ICU nurses, but the nurses that I work with in the operating room. Everyone has begun to appreciate the benefits, being that not only on-table extubation permits a neuro assessment in the intensive care unit more rapidly than if a patient's on a blower for 6 hours. They appreciate the fact that the patients are getting out of the hospital a little bit sooner if we accelerate their recovery in the postoperative period.
Thank you. I absolutely agree. Dr. Kim, we heard a lot yesterday about the importance of pain management in the thoracic patient. Could you share some of your experiences and successes with how you're managing pain in your patients?
Sure. One of the things that we kind of realized several years ago was that pneumonia was the #1 issue that we had after lung resection. And part of that was that we didn't have really good pain control. And once we saw the data on ERAS, we decided to adapt it in our program. And I think one of the things that we realize is that having this preemptive pain control makes a huge difference. So I tell my patients that in the past we used to say, okay, if you have pain, we're going to give you pain medication, and usually narcotics. But now the concept has gone to, okay, we know you're going to have pain because you had surgery, but we're going to make sure that it's going to be under control. And we've been using this multimodality pain control starting from in the morning of the operation. So they take usually Neurontin and Tramadol right before the surgery. We give intraoperative IV Tylenol, and some patients get IV Toradol. And then, and most other important aspect is that blocking the nerve that causes pain. We've gone to using Exparon, and we've seen dramatic improvement in pain control afterwards. And we have also adapted doing minimally invasive surgery. So going from thoracotomy to minimally invasive, I think we can control the pain so much better. And working with our anesthesiologist colleagues to ensure that not much narcotics during the time of the operation. And post-op, getting like around the clock non-narcotic pain medication has made a huge difference in terms of our patients.
I'd just like to add on to your comments. I think one component to the success of ERAS or ERAS in the cardiac surgical population is communication between the surgical team, the anesthesia team, and the nursing team, as well as the physician assistant team as well. If everybody gets on the same page and works towards a common goal, rather than the surgeon coming to the anesthesia provider trying to dictate the anesthetic, it works in a more positive manner and ensures success. Just one of the things you had asked me, the three components to, I think, the success on-table extubation, which is really, I think, part of the pyramid in accelerating an ERAS, is preemptive analgesia, gabapentin, intrathecal narcotic prior to going into the operating room, because that helps reduce postoperative narcotic requirements, and 3 IV Tylenol coming off cardiopulmonary bypass. And I think the IV Tylenol is a component because it's a non-narcotic. There are risks with it, but such as liver failure if you overdose your patients on it. But nonetheless, we are all finding ways to reduce our use of intraoperative and postoperative narcotic requirements to facilitate patient discharge.
And we're all hearing much, much, much about that in every newsletter that we get these days. So I know we're all trying to manage pain very differently than we have before. Dr. Grant, could you comment on some of the things that you've done with your bundle approach? And I was specifically interested in your concept of de-escalating mechanical organ support and how you do that.
Yeah, so I think it's a good segue, actually, because what we've really talked about here is that we've got discrete elements historically that are assigned to the preoperative, intraoperative, and postoperative phases. But I think what we're actually seeing is we're uncoupling some of those discrete elements from those phases of care. So a great example is extubation. It used to be we didn't think about extubation until we were in the postoperative phase. And so when we thought about putting this program together, we thought about, well, gosh, maybe there's a way for us to bundle all of these care elements somewhat irrespective of the phase of care and really attack outcomes. And so you alluded to the fact that we've looked at about 6 different kind of bundled packages. And one of those is de-escalation of mechanical ventilation or mechanical support in general. So elements of our anesthetics are short-acting, and as a result, we reverse in the operating room. We have a formal weaning protocol to get patients extubated in the operating room, and it uncouples a lot of those decisions that you would normally make post-operatively from the post-operative phase and makes it much more patient-centric. So the point is that when that patient's ready to have an element removed or de-escalated, we do that. And I think it's been very successful, at least for our data, is pretty encouraging early on.
I recall the days when we had clinical pathways, and I think one of the difficulties with those was that they were really unwieldy. They were, putting everyone in the same box. It sounds like what I heard from you all is you have protocols, but you adopt them to the particular patient so that they, as you said, can take their own trajectory, but all of us with an eye towards moving them a little differently.
I think the idea with protocols is they're good to a certain extent. And flexibility, as put forth in the STS presidential address today, is a key component to all specialties, not just cardiac surgery. And if we all learn to be flexible and learn to understand when we're going to deviate from protocol, it's an important component to that clinical practice of medicine, as well as the experiential effect of having gone down some pathways that you may not want to have gone down.
Yeah, I think one of the mistakes that people have taken when we're looking at things like enhanced recovery protocols is that they believe that it actually removes the autonomy of the provider. That the sense of this is that there's some a la carte menu of options that you get protocolized, and therefore you as a provider don't actually practice the way that you intended to practice. And in fact, I actually think this liberates you a bit as a provider and allows you to understand that there are certain elements that will automatically happen for your patient, and that you as the provider are still there to make sure that the relative contraindications, you mentioned a handful of those, relative contraindications are noticed. And then to your point, if I'm coming off of pathway, quote unquote, that's really a highlight of a patient who is at risk for either an associated harm or some resource utilization that's going to go above and beyond what was anticipated. And so in many ways, these pathways can highlight those patients early on and let you mitigate those issues earlier in their process.
Absolutely. And this was a seminar on multidisciplinary team. And so I'm very interested in how you've brought teamwork into your program, who was involved in the planning and rollout of it. Dr. Kim, would you expand on that?
I'm a general thoracic surgeon, and the first thing that I felt that was really important in implementing any kind of program is to make sure that there's a way to evaluate your program. So first thing we did was within the division that we had weekly meetings where we talked about what happened to those patients who got discharged, what's going to happen to the patients that's going forward. Once we had that in place, that encompassed everyone, the residents, the PAs, the MPs, and MAs, as well as the nursing in that group. We approached the anesthesiologist, and we didn't tell them about, okay, this is what you need to do. We said, who's interested? And we picked a leader who was going to be able to tell us, what's the best in
champion.
the practice. Champion, exactly. Because nothing worse than surgeon coming and telling you, okay, this is what you should do.
Love it.
Never do that. Never do that. So we found a champion, and Jessica Brown took that on in our institution. And we met and we kind of looked at the program, and I said, what can we adapt and what can we move forward, and then continue to evaluate. So it's a concept of just work together, because I am not an anesthesiologist and I don't know as much as our excellent anesthesiologists we do. And if you have champions, that's going to work. It's going to make everything better.
Our journey was a little bit different. The surgeon came to me with a proposal. He said, do you want to try to do this? And so our journey was more of trying to figure it out, and it was a journey of evolution. At the time, this is 2014, ERAS was out there, but actually, in all honesty, I had heard of on-table extubation at other programs, and being a cardiac anesthesiologist for 28 years, I was thinking, gosh, I hope I don't have to do that. So once the future arrived, and I was confronted with how do we do this, it then became an exercise of trying to, A, perform the on-table extubation, B, collect data to make sure what you're doing is okay, and C, it's almost, this process was the buy-in came over time. And now we started out at a period where people were rolling their eyes with what we were doing, because we had a very high BiPAP rate in the postoperative period, but now, which was 50% of the patients we were performing on-table extubation, but learning how to institute this multimodal analgesic therapy, or preemptive multimodal analgesic therapy. We now have dropped our BiPAP rate down to 6%, 9%, which is reasonable. And most of our, actually, we've only reintubated 3 patients over from 2015 to 2018. I'm including 2018's data.
So, I think one of the special pieces about the session yesterday that you referred to is that we're talking about developing a team of people who all have similar goals. You've established that objective, you've selected metrics for your service line, and people come together with like intentions. And when I presented from yesterday, one of the things that I felt very strongly about is that we have, I think, done a really nice job of articulating the technical elements, the protocols and guidelines of sorts. But what I think we've actually kind of missed somewhat along the journey is that the adaptive components are probably just as important, and that is things like establishing teamwork. How do you foster resiliency in your organization? How do you accept some of the setbacks, especially in the interim, as you're gathering that initial data, and then still forge ahead? And I think that for us, that's really been incorporated through things like a CUSP framework, Comprehensive Unit-Based Safety Program. We also have administrative buy-in. I mean, on top of being multidisciplinary and that all of our key players are at the table, we have a top-down approach too, where administration's really bought into this concept. And I think all of these individual pieces that are adaptive in nature are just as impactful, perhaps more so, than the actual rote protocol itself.
Yeah, I absolutely don't think anybody rolls these out and never changes them. There's a lot of tweaks along the way. But you also brought up a really important point. All of you want to look at your data. So we're statisticians at the table. Do you have, I mean, many of us don't have availability of, complex analytics. So, what sorts of offerings can you provide to others who might want to do this but don't have a robust data collection service?
So, if you don't mind, I'll go first, because I'm a private practice physician. So I think one of the issues that is going on in private practice at this point is learning to look at how you are doing as a physician. And it's important. So the way is to A, start data collection. B, learn statistics. C, if you don't have somebody who's going to help you do the statistics on your own. And that's what we've done over the years. But now we're getting to the point at our institution that since we are part of a healthcare system, the interest has begun to gain throughout the system that this can be a successful process, and there are more people that are getting in to then grow the concept of data collection. So there's a lesson here for the private practitioner, and I'd like to hand it off to Dr. Grant because he's affiliated with a much larger entity.
Yeah, I think this is a challenge, and I'd say that we have struggles in this regard too, maybe a little different a context of struggles. And ours comes from the idea that we are now moving towards things like big data systems, things like Epic, for example. And we actually had Epic roll out right in the middle of us putting this program together. And it's a bit of a double-edged sword because it offers tool sets that allow you to really put order sets in place, but it also makes it very challenging to receive that data back, especially if you had systems in place to accession that data beforehand. The only thing that I can offer is that many programs already participate in things like STS. And so they've set up frameworks to gather data in some form already. And it's not inappropriate for you to take that data alone and utilize that going forward to see whether or not you have markers of success within your own program. But if you want to expand it a little bit further, I would agree. There's a bit of a grassroots effort to this, and over the course of time, you begin to recognize that value, and then programs can start to establish whether or not FTEs should be, devoted to this concept. And I will say again, from experience, that we've seen an expansion across numerous service lines, the most recent being cardiac.
In terms of our program, we participate in the STS General Thoracic Database, and that data collector comes to our meeting every week. So she gets the fresh data every week. We kind of go over if there's complication and if it fits in within the definition and so on and so forth. But she also provides data back, and she gives us the data every 6 months, and then we look at it and said, well, do we see an improvement in terms of what we are doing? Now, the other focus that we took on was having postoperative narcotic discharge. That's not a data field. And then we started kind of collecting data in terms of giving patient questionnaire 30 days after and saying, hey, were you on pain medication before surgery, like narcotics, and then what were you taking afterwards, where we get real feedback. And that's an additional effort, but it's basically a one sheet, and retrospectively can go back and collect that data.
Who collects that data? And who does the follow-up to make sure that you get that data back?
So it's done at a clinic. The patient, while they're waiting for me, they fill it out 4 weeks later. So we try to simplify things and just focusing on what are the important things that you want to get out of this, and what are the data points that we want to get out. And from our standpoint, we want to make sure pneumonia rate came down, and STS data provided that. But the other question we had was, can we decrease the discharge narcotics, and this questionnaire kind of helped us. So I think if you do it in an intelligent way, I think you can be very successful. Epic is great, but it's a lot of data.
Sure.
So if you have a lot of data, if you don't have a huge data analytic group, it's going to be really hard to kind of get an intelligible data.
I think the other thing is billing companies are now beginning to get on board with this. They're taking all the data, everything, they're looking at charts as well, and they're beginning to compile methods of assessing and providing a metric of quality for private practitioners, so that when they have to discuss such things as reimbursement, they have some information behind them to go ahead and speak intelligently at the table.
And with patient satisfaction being a big component of that reimbursement these days, I can see that this is all, suddenly becoming of interest to your administrators. We've talked about data. Why don't you share some of your results? What are you seeing in your program with the implementation of cardiac ERAS?
So, a little bit of our data is related to whether or not we're extubating patients earlier. And what we've become very interested in is the idea of compliance with the various process measures. So I think one thing that's really critical about this is that no protocol is identical from one setting to the next. So, our protocol actually looks very different than your protocol, but that doesn't mean that we're doing something wrong. And I think what we're very interested in is whether or not compliance leads to improved outcomes. So our earliest data now has shown that when we have higher compliance with our intraoperative protocols, that we do extubate earlier, both in the operating room and at 6 hours, which is a major quality metric. But we're also seeing other trends. We are now doing a huge portion of our procedures totally opioid-free, and I think that's kind of a coup in the cardiac landscape. We're starting to see lower rates of organ injury. We're starting to see lower rates of atrial fibrillation. And so some of these early data, and admittedly we need more enrollment to know if these things are long-term trends. Some of these early data are really, really encouraging. And so as we press forward, the question becomes, which of these elements are really tied to those outcomes? And so that's where the majority of our work's been.
Yeah, you'd had some very interesting data about the higher degree of compliance, the more successful the outcomes were. So not surprising, but it's great to see someone documenting how effective we can be if we really are following our work.
Actually, inadvertently, we verify your data with respect to compliance. Because when we started the program, we have 3 anesthesiologists, but all of us couldn't get on the same page because 2 were not really cooperating. But over time, by presenting data to them on narcotic use, successful extubation, time of discharge from the hospital, length of stay, we began to see our compliance with those 3 measures, pre-op gabapentin, intrathecal narcotic, as well as IV Tylenol. Those metrics began to all rise up into the 70% level. If we look at our on-table extubation rate, no, it's interesting because it sits really roughly at 70% with respect to compliance.
And so again, perhaps there isn't much to be gained through those other 30%. They're just not suitable for that process, or the data will tell you that as you continue to look at it.
I think one of the things that we really focused on was that are we sending patients home on narcotics or not because of the opioid, kind of the epidemic. And one of the things that we realized from the ERAS, although it improved length of stay and all the other kind of measures, it didn't really change if they were going home with narcotics or not. And we kind of looked at ourselves and why am I sending that patient home on narcotics? I know that patient's not having that much pain, but why am I doing it? Well, I just don't want to get a call middle of the night saying they're having pain. So we changed our program and said, you know what, our standard is going to be, you're going to be going home Tylenol and gabapentin and Aleve, if you're appropriate. For after chest, and then for foregut, we kind of gone to just Tylenol and maybe Aleve. And it made a dramatic difference in terms of number of patients going home with narcotics. For foregut, I think 96% of the patients are going home with no narcotics. And that's compared to 100% going home with narcotics. And with that, I mean, I never realized how bad the narcotics are for our patients. Because once we kind of saw that data and then looked at our morbidity, we had less urinary retention, less ileus, and patients were going home, and they're so much happier. And I think that's where this can shift towards.
I think an interesting statistic regarding surgery and opioid addiction is that 30% of people that become addicted to opioids get their first prescription from post-surgically from the surgical provider. So really the lesson is we need to all hone in on this issue because it's very important for our patients as well as we can make a difference as far as outcome and affecting society as well.
So I think you hit on something pretty key there, and you guys have taken the next step. And we talk a lot about the phases of care and whether or not you're doing certain process measures. But one of the things Enhanced Recovery can provide you is actually a framework to install other interventions. And this is a perfect example. If your prescribing practices make no sense, well, that's a process measure in the perioperative paradigm. So why not, at some point, take a look at that practice and make an alteration?
Right.
You don't necessarily need grade 1A evidence to know that your prescription practices are a bit amiss. You can still install something that's very sensible within that framework that gets to the heart of the problem.
When I first started, I thought I would get a call every day, with patients going home without narcotics. And first 6 months I got 0 calls. So in my mind I said, wow, this is amazing.
But there's also data out there that supports that concept, the fear of the call.
But the thing that I did realize is that it's easier to do that when patients saying, I'm not having that much pain, to get them home without narcotics, right? So this only works because of the ERAS, not necessarily everything else. One last point I'd like to make is that it's amazing, patient engagement makes a huge difference. And so now, like we tell them about, okay, this is preemptive pain management program, and this is what you're going to go home with. And I tell them 6% of the patients don't take narcotics after this. And their expectation is not to take narcotics. So when they go home, their expectation is they'll be fine, and that makes a huge difference. Just because,
Yeah. My final question to all of you as we run out of time is asking for the special sauce, and you lead me to what I think as a nurse the special sauce is. It's a well-informed patient. And when you have that conversation with them and clarify those expectations and give them that clear message that, you're not going to be going home with those things, it does become a self-fulfilling prophecy. But I'd love to hear from each of you if you think there's one thing that really turned the corner for you, what it might be.
Yeah, I'll highlight two things. I'll echo what you said a bit about the patient experience and the patient expectations. And for us, it's really about bringing the patient into the care team. Mm-hmm. So, it's said a little bit differently than what you said, but, the idea here is that they're the engaged partner in this entire thing. I often talk about if you go and buy a cell phone and you're told that you're going to get a certain plan and you get something different, that's a setup for error. It's a problem. And the fact that we in medicine couldn't figure that out until just recently is pretty appalling. So when you bring them in, it really fixes a lot of those ills. And then the second piece I'd say is that none of these exist without really championing the cause through the culture, not only in your own kind of your service line, but through the surgeons. And one of the things I don't want for anybody to take away is that we marginalize the surgeons' roles in these protocols. They really are still the vital captain of the ship in many ways. Yes, we're bringing multidisciplinary teams in to be able to do this, help that person do their job. But it's vital that you have a champion on that surgical side as well.
I just to put it succinctly, it's getting a team, creating the team, and making sure everyone on the team is going to play nice in the sandbox. If a football team's a great example. It takes every player on that field to lead to success. It takes every player in the institution, from the perfusionist, surgeon, nursing, physician assistants, the person who greets you at the door, who says your admission time isn't going to be 5 days. We're going to try to get you out of here in 3 days. All these concepts come together to set the patient's expectation. What goes on in that preoperative consultation? The surgeon is the captain. You're right. He also realizes, or she also realizes, that every member of the team has got to do their part and execute their part. So I think that's the secret sauce.
Yeah, we heard a lot of teamwork yesterday. Mm-hmm. Dr. Kim.
Yeah, I think evaluation and communication, meaning evaluate your program and communicate with everyone about the program. So perfect example was around-the-clock Tylenol was one of the key components of our post-op pain regimen. Nurses didn't really know that. Nurses kind of talked to the patient, do you want Tylenol? Patient said, oh, I don't have pain now. And then nurse didn't give it. Did that work? I mean, we had best laid plans, but nurse didn't understand the importance, or the patient didn't understand the importance. So we can come up with a lot of plans, but if it's not implemented correctly, it's never going to work. So I think constant evaluation and just kind of get the message out there that this does work if you implement it well.
Well, thank you all. I really enjoyed all the presentations yesterday. I think this will be very helpful for many, many of our audience members and society members. So thank you so much for your participation, and enjoy the rest of your trip. Thank you from San Diego.